Hi, I'm Dr. Randy Martin. We're here at the AATS Mitral Conclave 2017. I'm thrilled to be joined by Dr. Gilles Dreyfus, who all of you know. So we just had a fabulous debate on functional tricuspid regurgitation, and Tyrone David blamed you. You're the whole, that ruler that you put in there and measured the tricuspid annulus. So where do we stand with functional TR, when to repair? What do we know? What have we learned?
Well, I think we still have a lot of questions,
Right.
to be honest. I still believe that, as I said during this debate, we have problems with grading and quantification, and I think that you know better than I do. You're a cardiologist, I'm a poor surgeon, and I don't know as much as you do, but I mean, if I read the books, it says that between none and mild and severe, there is a gray zone which everybody calls, when it suits them, mild, moderate, or when it does suit them, moderate, severe.
Right.
So basically, I also insisted on the fact that it's very labile, and therefore, with just an increase in medical therapy, the same guy with the same annulus will probably show some degree of moderate, severe, and a few days later will show mild or none.
Right.
So, now, the other fact which I think we're sure of is that you can dilate your tricuspid annulus, and we have not clearly identified the risk factors.
Outside of atrial fibrillation.
Atrial fibrillation, we will present some data at the AATS meeting, because we've been studying two groups of patients for an average of 5 years, up to 10 years or 11 years. And we've been seeing that there are some risk factors you can identify. But still, it is difficult to understand. I personally fight quite strongly against the so-called pulmonary hypertension. And what I think is that we need to stress that patients, despite being asymptomatic, have big ventricles, and they don't have high pulmonary pressures, but perhaps the remodeling of the left ventricle can induce also remodeling of the right ventricle. Right. And can have an impact on annular dilatation. I don't know why they have annular dilatation, and truly, this would be very presumptuous to say I know, I don't know. Now, the other fact, for sure, is that I have not validated this 40 millimeters, and when you search in the literature, you start, in the guidelines, you start by my article of 2005,
Correct.
which is a surgical analysis of 70, which is exactly perpendicularly to what is measured by the cardiologist by echo in 4 chambers view.
Okay.
And this 40 millimeters, which was not even the 40, was 21 millimeter per square meter in rheumatic patients given by Colombo. And suddenly, out of the blue comes 40. And then everybody says it has to be 40. Now, there's one thing I'm sure of, is that you need to have the tricuspid valve being assessed by specialist cardiologists involved in valvular disease and in echocardiography, because it is very difficult. Because the parameters influencing the right ventricular volume, contraction, loading condition are much more complex, and the annular shape of the tricuspid valve is very complex. Right. So I don't think that we can have reports coming from referring cardiologists saying there is no TR, or there is mild TR. Today seems to be insufficient. And so I know what we don't know, but I cannot give the answers to the question you're asking, is where are we going to? I decided that as I was looking, I did really say on the podium what I really have gone through, is that I operated hundreds of mitral repairs in my life, thousands, and then I looked at the tricuspid, at the right atrium, which seems to be very dilated, the right ventricle very big, and I said to myself, this is not normal. Just open the right atrium to see what was going on. Right. And had the idea to measure this tricuspid valve, and obviously, why did I take this 70 millimeter? Because you need to take 1 day of value, which is there to be criticized. It's not, when you first throw a sign or a measure, it is not a golden measure, and it's there to be criticized.
Let me ask you. Let me ask you. Who would you do tricuspid repair on?
No, today I based my indications on patients, irrespective of the grading, on 40 millimeters. Above, I treat. Below, I don't treat.
Regardless of the
the
so
grading.
you're doing essentially what David did. He followed you.
And
right?
I follow the guidelines.
Okay.
No, but look, now you know whether the guidelines are wrong and that then they need to be rewritten by experts.
That's what you do today, though.
That's what we do today, and that's what we're going to present at the ATS. So that we know we are just saying, look, this is what we've done. These are the results. Will they be strong enough to convince people? I don't know, but the problem is very difficult because everybody uses arguments that to me are very weak. Is patients don't have symptoms. We know that it takes 10, 15 years for a right ventricular dysfunction to get symptoms.
And when they have symptoms,
it's
they're really sick.
Okay.
Right.
And the second thing is that we don't get reoperation. But look, there are no indications for first-time tricuspid regurgitation. There are even less for second-time tricuspid regurgitation. And again, we carry on with the statements that secondary TR is a deadly situation. Well, we know that patients don't die, most of them don't die due to surgery or the right ventricular function. They die because of biological dysfunction,
correct.
High INR, liver dysfunction, high creatinine, renal dysfunction. And so basically these patients are far gone and they're too much away from the indication. But it is not a criteria that is really reasonable that you can raise to say, well, it's not a problem because patients don't come back.
So in conclusion, we need more information. Is that correct? I mean, does Tyrone and Hartzell have a position, and you and David appear to have a position?
No, I don't think that with Tyrone I'm so much away because, the problem with Tyrone is that he's a strong-minded person, as I am,
right.
and he doesn't want to admit, but he says off the record that he now puts rings to patients with severe and moderate TR.
Right, he said moderate.
So we're coming
close.
We're coming very close. I agree that there is an etiology which triggers TR. I agree probably that the long-standing course of mitral regurgitation, although it's unclear because asymptomatic, we don't know if it's not a long-standing. Because why some patients do dilate, why patients don't dilate. We don't know that. I mean, I'm talking about left-sided disease.
No, I understand.
Obviously, patients with AF are those patients who dilate the left atrium and the left ventricle, and they can be asymptomatic, and because they don't have high pulmonary pressures, and because it's only the pulmonary pressure that gives you symptoms. And so it doesn't mean that because you have lower pulmonary pressures. And by the way, we're presenting another paper at the ATS where we compare mitral, we give our techniques for mitral surgery, and we compare asymptomatic and symptomatic. We don't see a great difference in sizes or in pulmonary pressures whatsoever.
So we need more information, basically.
We're in a field which is a very touchy field. And unfortunately, despite all the imaging and everything, we have a real problem there. It is that, even if you use MRI scan, for instance, you cannot overcome this loading condition that changes completely the geometry and the regurgitation. So it's a difficult issue, and until we don't have a clear answer, but as I said, a prospective randomized trial needs to be very well designed in order to answer just one question. And we'll probably move step by step. We will not have, even from a randomized trial, a definitive conclusion on this subject.
Well, listen, I appreciate you bringing the subject up. No, but I think it's a very valid, very important question, okay? And you certainly were the leader in this, and I appreciate all your tremendous contributions in this field, and you've stimulated the giants.
What is the pleasure? Despite the prospective randomized trial, we have many years to meet together and have interviews about tricuspid regurgitation. We're not progressing at all.
It's like an annuity. Thank you very much. Thank you for joining me, my friend.
It's a real pleasure.
Thank you. And thank you all for joining us.